Thank you very much, everyone. Good afternoon. It's a real treat to be on the podium. I haven't been up here for nearly 20 years. I'm also really pleased that Asif introduced me, not Roger, because the last time he introduced me as James Malone Lee, which was very confusing for you, but quite distressing for me. Can everyone who puts male slings in the audience raise their hand for me, please? Okay. Can everyone who puts any of these slings in the audience raise their hands? Just one. So this is these are deviant procedures. I'm not going to talk about them very much, but there's a variety of, there are two types of male sling. They fall broadly into two groups. There are bulbar compressive slings, and then there are retrourethral slings. The bulbar urethral slings fall into two types. There are the fixed ones and there are adjustable ones. So the Invance from AMS, which now I think is off the market, is a bone-anchored fixed sling. Bone anchors and continence have never gone well together. Virtue from Coloplast is a kind of hybrid between a retrourethral sling and a compressive sling, but I'm going to put it in this group. There are some adjustable slings. One involves a sort of adjustable buckle type mechanism, and there's another one which involves a subcutaneous injection port. There are only very small series for all of these, and they've all got very different and unique complications, so I'm not going to discuss them in this short talk. The most commonly performed male sling in the UK is the Advanced sling, which is a retrourethral sling. This is a transobturator tape which is sutured to the bulb of the urethra after partial division of the central perineal tendon. The tape is then tensioned, which results in proximal relocation of the bulb up into the pelvic outlet. This is supposed to have three actions. Firstly, it's supposed to functionally lengthen the membranous urethra. It also realigns the urethra and also provides a backstop, a little bit like a mid-urethral sling. This is really hypothetical stuff. There's a little bit of evidence from MRI and cadaveric work. It certainly seems that they're not obstructive slings. Just because they don't urodynamically cause obstruction with voiding doesn't tell you how they work, but certainly they don't seem to cause obstruction. This results from the largest of two urodynamic series, and the PDEC Qmax and maximum flow don't seem to change. Patient selection for when putting out for stress incontinence is very straightforward. I think it's important to pay attention to the very basics, like taking a proper history and looking at the bladder diary, because men after prostatectomy can just have overactive bladder. 24-hour pad testing, I think, is extremely important. Relying on number of pads a day is a bit of a disaster because the capacity of pads varies from 50 mils to a litre a day, so don't rely on pads. A lot of fuss has been made about doing dynamic flexible cystoscopy, where you fumble around the man's perineum, prodding around his perineum whilst you're doing a flexible cystoscopy. It's not very nice, but some people put a lot of weight to this retroluminal support test. I've got two videos here. One's of a man post-radical prostatectomy, which I've put as the good DSM. You can see there's a relatively good reflex contraction when you finger his perineum. On the other side, there's a rather gloomy view of a post-Turris TURP where, nothing really moves. And these have been thought to be something that can guide you. I'm very surprised that some people don't do urodynamics before putting in one of the, any devices for this, but I would certainly say it was mandatory in my opinion. I'm not going to go through the surgical implantation technique, but talking in a few groups, there still remain a few controversies. I think they're less controversial now. Most would agree that partial division of the central tendons is what required. Some surgeons I've met in America don't divide the tendon at all. Certainly, complete division can usually result in the hammock falling off the back of the bulb. Originally, the tensioning of the tape was very enthusiastic, with talk of the knees being in the perineum and pulling as hard as you can. Don't really think that's necessary. What you really want to do is just see the bulb relocate nicely into the pelvic outlet, as seen in the picture on the right of the screen. Since the XP came out, and that's different from the original tape, it's got little barbed edges which makes it hold in the tissue a bit better. I don't think there's any need to tunnel the tape. I think some people still do. Intraoperative assessment of the sling isn't something I particularly do. I don't really understand the value of assessing sphincters in people who are anaesthetized, but some people pay weight to it. And I don't know how many people look inside to see if they've put the sling into the bladder. I certainly don't, and I've certainly not heard of any cases, but it can certainly happen with transobturated tapes in women. There aren't any really very good quality results. It's all level 4 evidence. This is still remaining the best of the bunch. Multi-center paper from 2012, 156 patients. Interestingly, a broad selection in terms of the volume of leakage from mild to severe. Overall, you can expect a success, whatever you mean by that, in about 75% of patients, usually half of them cured and 25% improved. The index patient for a male sling, really inspired from George Webster's work, and what you'd say sort of 4 or 5 years ago would be a man who leaked less than 250 mils per day by pad test. He would have had a radical prostatectomy, not a TURP, and you could take 10% off the success rate if he'd had radiotherapy or bulking injections. There are lots of small series about the other parameters on the list that are influencing outcome, but they're small numbers and they're not controlled series. We don't really know what to do if the primary sling has failed. You can take the gynecologist's approach, which is just to put in another sling, and the results seem to be average at best in small series, with success rates ranging from a very poor 50% up to 70%. Again, in small series, artificial sphincter placement as a secondary procedure seems to be better. Certainly, it's no different from really putting in from putting an AUS in the first time. You don't really seem to see the sling. Some data out from Webster and Peterson just this last couple of months has done a small comparative study of secondary placement of AUS versus a sling, and although there are some problems with the mix of the groups, there were certainly a lot more radiotherapy patients in the AUS group. Even when corrected for that, the AUS was much more successful. We don't really understand why primary sling may fail, whether it's some characteristic of the patient or something is wrong with the surgery. There's been an interesting MRI study paper which came out last year, which shows that if you do a high-resolution MRI, you can really powerfully predict which people who've got slings in have failed and which are successful. And you can see on the picture that says continent, there's a red arrow pointing to a notch in the urethra. That's where the sling is. And that really reflects exactly what you see when you tension the sling intraoperatively. On the left, it looks unchanged. Now, this doesn't help you guide you to say, well, let's put another sling in, because you don't know why it looks like that in the first place. But it is interesting nonetheless. Complications-wise, probably about 10% have retention, and this may be of good prognostic value for their continence in the longer term. About 10% will have problems with short-term chronic pain. De novo OAB doesn't seem to be a problem, and I've asked around a lot looking for if any of the big centres have had any experience of having to take tapes out for late chronic pain. Both Dirk de Ridder and Françoise Harb say none, but it's early days yet. I think we've heard a lot today about mesh. Mesh isn't inert. If it was, it wouldn't work. We rely on the body's tissue reaction to send fibroblasts in, and it's a very crude form of tissue engineering where the mesh is a permanent scaffold. And I think we've got to learn lessons from what we're hearing today and not repeat the same things. It'd be very sad to see the same cycle of complications, mini slings, how to remove tapes, and then autologous tapes repeated again, with men probably plastering themselves to the Houses of Commons saying no more mesh. But it could happen. Very importantly, there is a randomized controlled trial going on in the UK. It's the only randomized controlled trial in the world of male sling versus artificial sphincter. It's randomizing 180 men to each arm. It's a non-inferiority trial. The primary outcomes really are efficacy and cost effectiveness, and the secondary measures are really related to harm and other items. There are lots of centres in the UK, and I would urge you to support this trial. If you just Google Master Trial, you will find it very easily. There's lots of very helpful and simple information for surgeons and patients on there. And also very helpful to referring prostatectomists if they could refer in on the basis that the patient needs treatment rather than just a little sling, or so that the patient doesn't come with any pre-bias about what they're going to have. So in conclusion, we're nearly into a first decade of male slings. They seem to be effective, but we've only got low quality evidence. We need quality evidence about the efficacy. We need evidence on how to select the patients. We don't know how to manage sling failures yet, and we really have to be cautious about their long-term safety. So please support the Master Trial, and thank you very much.
Thank you very much, James. Just one thing, I mean, just on the back of the female sling talk, I'm a little bit worried that you're going to end up in a similar problem. I mean, I get this campaign group, Women Against Mesh or Slings, accosting me on the tube, and I normally just give out Jeremy Ockram's number. But should you as a group not protect yourself against that in the future? Because it may very well happen to the male slings, just wanting them out. I mean, how are you going to have a governance structure?
Well, I think it's a real problem, and I don't think I can really address it without talking about the women. I mean, it still really amazes me that the MHRA can put out reports saying there is no evidence that meshes are unsafe, when what we really need is some evidence that meshes are safe. And I think we're in a really difficult spot. I don't think there's anything we can do to stop this happening. The key players in male slings in Europe certainly haven't seen anything like what they've seen with women in 10 years. So maybe there's just something very different. Maybe it's just the presence of the vagina and the vaginal flora. But I'm really surprised, because of the way that mesh reacts with the body, that chronic pain in men hasn't been a feature. And I think as more go in, we might have some surprises.
Just Chris Harding on microphone 1.
Yeah, I just want to comment on the urodynamic data, which I find very surprising, I must say, based on the fact that firstly there's an incidence of retention associated with this procedure. Secondly, the MRI pictures that you showed are fairly convincing, showing that the outlet or the urethral lumen is certainly affected by this procedure. And thirdly, my own anecdotal experience of patients who find it very difficult to void after this procedure, they almost to a man say that their flow is reduced. So I find that urodynamic data very surprising.
I think that's the problem with urodynamic data, full stop. It doesn't really ever reflect what we want it to show. The urodynamic data in the lab and what's going on in every day is very different. But I agree with you. It's certainly in the short term, when you've put a male sling in, there's obstruction, and the men, I've had men say, oh, I'm really slow, and then 3 months later, they're happy again. But men tend to not be that bothered by poor flow when they're dry again.
Oh no, I agree.
Yeah.
You know, the question or not whether
Yeah.
it obstructs is separate to whether or not the men are happy, because a bit of obstruction is, for argument's sake, what they may need.
What you'd expect there, if there was more of a significant obstruction, is the development of more de novo OAB, which we're certainly not seeing
I agree.
in the numbers we're getting through.
Simon, microphone 2.
It was really to answer the flow question. A man who's had a radical prostatectomy who's got stress incontinence has a pathologically good flow. So when you correct their continence with a sling afterwards and they go back to having a normal flow, they often tell you that their flow is poor. It's not. It's normal, as opposed to pathologically abnormally good. Less than what it was when they had no obstruction at all, because their prostate wasn't there.
Okay, just a question from Jeremy Ockram.
I just want to make a comment about the newness of these techniques. In fact, bulbar male slings were around in the 70s with the Kaufman cuff and the Kishev cuff as well. They had outcomes of an order of 50 to 60%, in other words, almost identical to what we're seeing 30 years later. And they had discomfort and pain rates of about 5 to 8% with 2 to 3 years follow-up.
They weren't retrourethral though, Jeremy. They were going across the urethral lumen.
Well, I mean, we can argue about the exact placement and the exact mechanism, but they are similar in nature. Different materials, though.
I don't think it's the material. I think, you know, I mean, that's why I think it's important to separate them into the groups that are the bulbar compressive slings and then there are retrourethral. I'm not a big proponent of any of this stuff, but I think there is a big difference between the historic male slings.
Okay, thank you very much, James.
Thank you.
So